Okay, so we are live onto YouTube, Aarti Madam and Shilpa Madam, and you people can start.
Yeah,
Madam, you can time it. Yeah,
I'll just take a minute. So I will welcome you to this new session on BLAST series. So this will be brainstorming and learning from case-based scenarios. I think as clinicians, we tend to get very busy and we forget our postgraduate training where we used to do this day in and day out with our professors. So Dr. Aarti Deenadayal, who is a very dear friend of mine, who is so good in her clinical work with the workup of the case and also with her teaching skills, she has taken this initiative to share her clinical skills in each scenarios. So this takes a lot of effort, unlike a single topic discussion where we just come and discuss it for 10-15 minutes. This is a real time case discussions, which she might have had it, or people or members who have sent it to her, she will be discussing. This will be every week on Friday. This again, we will have Dr. J to give his perspective in terms of diagnosis, in terms of the available literature, what it says, and also about the treatment options. So we will again continue discussing in the WhatsApp groups. If there is anything which is left over, we want to keep this short, like say 20 minutes, max like 25 minutes. And Dr. Aarti is a very busy practitioner, but in spite of that, she wants to share her knowledge with all the members across India. And I think teaching faceless people across the screen is something which is now I consider it as a very noble work, because without expectations, they prepare and they come here to do their best. So over to you, Dr. Aarti and Dr. Jay.
Thank you, Shilpa. That was such a sweet introduction. Thank you. And I'm really excited to start off today's session, the BLAST series, where we plan to brainstorm and learn from case-based scenarios. I'm sure you all agree that every case is very unique and the management is very, very situational. And this is the reason why we want to discuss the cases. We want to learn new perspectives, and we want to understand that there are many, many ways to reach the good outcome. So with this, can you see my slide changing, Shilpa? Yeah, super. So we posted these polls all across, our groups, and I must say we had a fabulous response. And the reason why we chose to discuss about adenomyosis is because, as you rightly said, Shilpa, it's very controversial. It's a very challenging topic. The outcome is not always good. Medical management works for a very short time. Surgical management, again, most people are not very aware of the options. They're not very confident about the outcome. And I think it's time that we discuss about different perspectives to the management of adenomyosis. What we plan to do in these BLAST series is that the topic for the BLAST series will be announced every Wednesday, and we encourage everyone to participate in the polls. Post your questions, your cases in the group, so that we too can understand what are the burning questions and try our level best to understand them. Now, without wasting further time, let's start discussing the cases. Jay, we would love to hear your perspective on all these cases I'm putting forward. And I must confess that Jay is not aware of any of the cases which I am presenting today. And he wanted it that way. He said, I want to be spontaneous. I want to, give my perspective to whatever you are going to present. So Jay, this is the first case over here. And she's a 26-year-old with 2 years of married life, intractable amenorrhea with vomitings, and she's bedridden the first 3 days of her cycle, and sometimes even needs to get admitted for her pain relief. So this is a very common scenario we see in our clinical practice, and many of us wanted to know the pointers on for ultrasound diagnosis of adenomyosis. And you can see over here this particular case on ultrasound has all the pointers, has the entire fan-shaped ecogenicity of the anterior myometrium, their myometrial cysts, and there's a junctional zone which is not very clear. And Jay, what is your perspective on managing this patient? How would you offer pain relief?
Yeah, I think 2-3 things which are interesting with regards to this. This seems to be more like fundal posterior adenomyosis. Okay, at least from the image which I can see. Second thing is, because we can see a triple line at a lot of places through the ultrasound. So even though the endomyometrial junction is distorted at the posterior margin, this seems to be a little young lady. Okay, because usually as people age with adenomyosis, okay, the junctional zone keeps on getting disappeared more and more. All right. One thing which I wanted to ask you, which we would normally look into, what is the size of the uterus here? It seems to be more than 10 centimeters.
Yes,
okay. It seems to be, okay, I could be wrong, but visually it seems to be more than 10 centimeters. Okay. Second thing, see, normally, even though, the posterior wall is much more thicker compared to the anterior wall, based on this ultrasound. Okay. One thing is important here, as far as this report is concerned, is that even the anterior wall is thicker than normal. The normal anterior wall is not so thick for any lady. Okay. And that itself means that she has a large amount of globular adenomyosis, which is present inside her uterus. From whatever little ovaries I could see, I could not make out the sliding sign, honestly. But usually such a large adenomyosis is going to be associated with endometriosis. Usually it is going to be associated with some or the other form of intestinal bowel adhesions, rectal adhesions, and all these things, because that is a part of the same disease, endometriosis and adenomyosis. Honestly, if you ask me, what is going to be the plan of action for this patient? Okay, this is a candidate who has to straight opt for surgery. The reason being the simple size of this adenomyosis. Okay, now on there is going to be a little argument that no, you should give GnRH agonist and reduce the size and all these things, or you can put a Mirena if she's consenting to be okay to lose her hymen and all these things. But frankly speaking, once the size of the uterus exceeds 10 centimeter, okay, once it exceeds 10 centimeter, then practically medical line of management has got no role. Okay. Second thing which we look at in surgery is, see, if you look at the tip of the endometrium, no, at the fundus, where the tip is there. Yeah, from there, what you just marked, no, madam. From there, you have a huge zone of the uterus, which has a wall thickness of more than 4 centimeters. Yeah, huge zone. Okay. Now, whenever this huge zone is present where wall thickness is more than 4 centimeters, practically medical line of management is not going to work. Okay. This is of course not mentioned in any, I don't have an RCT to support all these things, but I'm just talking from practical experience, because adenomyosis is something which we do 5 cases a week at least. Okay. And yeah, so if you ask me, this is a girl who is going to straight opt for flap reconstruction, honestly, and surgery should be the treatment of choice at this size.
Jay, what is your choice of painkiller? Because many of our colleagues wanted to know pain management in adenomyosis.
At this size, you mean to say at this size of the uterus?
Yes, any size. I mean, the patient coming with adenomyosis and that severe dysmenorrhea, incapacitating dysmenorrhea, what NS would you prefer? First, let's go through, what is the basic oral pain relief you would want to give this patient?
See, majority of the people are going to use a combination of, either mefenamic acid plus any antispasmodic. So majority people would use meftal-spas or something like that. Right. Okay, to take care of prostaglandins as well as the spasm in the muscle. Okay. Right. But again, if you ask me practically, the thing which works the best, okay, for something like this is to put a tramadol suppository. It is supridol. It is commonly available, and you can put supridol suppositories twice, thrice in a day in order to get the pain under control, because this bulk of the uterus is going to cause severe pain. There is no doubt in that. So if you ask me, I like to give patients supridol suppositories. It is something which is easy. They can self-insert it. and a lot of people, are okay with supridol suppository, which is tramadol suppository. Okay, it's 100 mg tramadol.
Okay. Okay. Now, is there any injectable you prefer? Say the patient is not really responding to the tramadol suppository.
Again, 2 or 3 injections would work. The only thing which you should not give is injection just paracetamol. Okay, that is something which doesn't really work very nicely. But you can give diclofenac injection, provided the patient has no allergy. But again, rather than giving injectables, I think suppository is a much better option, madam.
Okay. Okay. Now, suppose this patient did not, you just mentioned that if the uterine size is more than 10 centimeters, you would prefer for a surgical line of management. Now, suppose this
primary surgery. Yeah.
Yes, primary surgery. Now, suppose this patient's uterine size was, say, around 6-7 centimeters, but she was having severe dysmenorrhea and she did not want to go in for surgery immediately. What is your opinion about progesterone IUCD? Say she wanted to delay her childbearing for a while. What is your progesterone IUCD?
See, if progesterone IUCD is good, one. Okay. Second, it doesn't do anything to the size of adenomyosis. It just causes pain relief. Okay. If you want to reduce, if you want to cause any form of volumetric reduction in the size of adenomyosis, you have to give an anti-estrogen along with a progesterone. Okay. So you must try to give, if you want to put if you want to put Mirena only, let's say a hormonal this thing, then the thing is you put Mirena along with letrozole. Okay. If you don't want to put Mirena, then you give letrozole plus registrone. And that is to be given either continuously, letrozole continuously for 3 months or alternate day for 3 months. And registrone is to be given daily with this. Okay. So that is something which will cause some shrinkage, 10 to 15% shrinkage in the size, the volume of the uterus.
Okay. Okay. So you're saying with Mirena, give letrozole along with registrone as well. And this is for a period of, say, 3 months, and then you would again reassess on ultrasound and then take it forward. So how long can you give this protocol?
Max is 3 months.
Max is 3 months. Okay. And just one line answer on what is your opinion about these alternative hormone strategies, OC pills, because these are the prescriptions we see commonly given with adenomyosis.
Size less than 8 centimeters, globular adenomyosis. OC pills will work.
Okay.
Between 8 to 10, you need to have registrone plus letrozole because you need volumetric reduction in order to achieve pain relief.
Okay. And progesterone only pills? Again, we see many of our patients.
It will not help you. It will not help the patient, honestly.
Okay. And what about GnRH agonists, and for how long?
See, GnRH agonist, try and understand the concept. In adenomyosis, GnRH will work because adenomyosis is due to glandular proliferation inside the uterine musculature. Okay. So wherever you have glandular proliferation, it will cause down regulation of the receptors, which will itself introduce some form of apoptosis inside those fibers. And once that happens, till you maintain GnRH suppression. Okay. So let's say you are giving depot 1 month, 3 months, whatever. Okay. In that situation, it's going to be fine. But apart from that, nothing. Maximum is 3 shots. I'm going to, since you mentioned about this and since people are madly in love with GnRH agonist, that's predominantly to avoid or to take over the, let's say, surgical skills. Okay, let's just put it that way. We are operating one patient on Monday. Okay, she's admitted in Global Hospital right now under my unit. Okay, she's undergone 6 shots of Lupride. Okay, and she's come to the hospital, in fact, as a surgical emergency with avascular necrosis of the femur neck. Okay, because these drugs are known to cause osteoporosis. It is just that we know it, but we don't tell it to the patient. We don't accept it. Okay, and so she's got this, and currently there is a small intertrochanteric fracture. So the ortho is going to be assessing tomorrow morning because she's feeling severe pain in that joint. All right. So this is something you need to be careful about. This is the 7th or the 8th case of a pathological fracture post GnRH agonist, which I am seeing in the last 6 to 7 years already. And people who have not seen it is because that patient has never come back to them again. That patient has gone to somewhere else. So I think apart from that, it should be a very important take-home point, in my opinion.
So this is a very superb analysis you have given us on medical management about pain relief, about anything less than 8 centimeters. If you want to postpone surgery, you can consider regestrone and letrozole for a maximum of 3 months, and do not continue giving GnRH agonists for more than 3 months. And you just explained about the complication which you have seen with prolonged agonist use. So moving on, Jay, this is again a case of a 30-year-old. And can you see the video play, Shilpa?
No. Yeah, I can see it play.
Right. So she has a normal ovarian reserve, normal tubal factor, normal male factor, 4 previous first trimester miscarriages with, of course, severe menorrhagia and dysmenorrhea. And you can see gross adenomyosis. Now the bladder is here. So this is the posterior wall, and you can see the endometrium is somewhere here, and this is the anterior wall. So what is your plan of management for this patient?
See, honestly, from whatever I can see at least, okay, there is one thing which I noticed. You have to increase the angle of the ultrasound probe in order to get a clear picture, and you have to reduce the depth as well. Okay. Which itself indicates that this is a large volume adenomyosis. That is the first thing.
Right.
Second, junctional zone, at least I can't see. Okay. Absolutely. Yeah. And this type of patient will need surgery for pain relief. Right. Because even if you do a surgery, trust me, that junctional zone doesn't really come back after surgery. You may have to do IVF or whatever, but even in IVF, the success rate of this type of procedure is going to be less than 15%, because what has happened is, a lot of time, people who don't operate so much of adenomyosis, they often like to comment that, in adenomyotic surgeries, you should not open the endometrial cavity. Okay. People really don't, and I also don't understand the concept, how they can talk like this when adenomyosis actually originates from the endometrial cavity. Okay, the reason why you see the sun ray appearance and all these things is because the origin is somewhere in the endometrium. That is the reason why you have a spoke. Otherwise, the spoke should come in the reverse direction, or otherwise the spoke should be in the craniocaudal axis of the uterus. Why is the spoke right beginning at the endometrial cavity and going back? Okay, the reason being, some of the origin of any adenomyoma comes from the endometrium. So basically, whenever you do an adenomyomectomy for something like this, okay, chunk, let's say 10%, 12%, 14% of the endometrial cavity is going to get compromised. Okay, and that particular chunk has to come out. When that chunk comes out, okay, people often say that will distort the endometrial cavity, and what type of regeneration will occur. Yes, we do agree, it will distort, but then just like how you do a hysteroscopic myomectomy, where also you are distorting the endometrial cavity by cutting off a lot of the fibroid, you are cutting off the endometrium, basal endometrium, and you are entering inside the uterine muscle. Still, uterus is kind and God is kind that it allows lateral epithelialization to occur. Okay. And the same thing will occur in adenomyosis. But the only problem is, if you don't take out that endometrial cavity, okay, that little part of the endometrial cavity, this endomyometrial junction will stay as bad. The minute you take it out, you will allow a new endometrium to grow at least over that patch. Okay, though the cavity will become slightly narrow, tubular. Okay. But you will have some triple line appearance sort of a thing which will start developing, and I think that is very important. But I want to mention one more thing. See here, no madam, in this ultrasound report which you have mentioned, you can see the adenomyosis extending right up to the serosa. Right. Plus, it is not a very globular adenomyoma. It is something where there is adenomyosis, but one part is having much more adenomyosis. This typically falls into the category of something called as focal adenomyosis of outer myometrium in association with such a large adenomyoma. Okay. These patients will have deep endometriosis and bowel nodules in more than 60% occasions. Okay. So I would like to evaluate that also in this case.
Right. What are the challenges with such surgeries, Jay? We are not talking about you because I've seen you operate adenomyomas and very large globular adenomyosis as well. But commonly, most gynecologists.
Location of the endometrium. See, that is the biggest problem. Second is people don't know how much to resect. People know how to resect. They will take out a small wedge and say adenomyomectomy done. Because a small wedge will also take out 10% of the adenomyoma. But in order to cause great pain relief, okay, you need to excise at least more than 65 to 80% of the adenomyoma. And that you are going to achieve only if you have a very good pre-ultrasound with you. Okay. Right. Where you will know how much you have to go, where you have to go. Okay. One more thing I'll tell you. If you do a very good adenomyomectomy, especially for globular adenomyosis, it will cause automatic delinking of the fallopian tubes. Because what will happen is you will end up entering from the posterior to the lateral planes. And when you enter from the posterior to lateral planes, actually the fallopian tubes are still posterior because the cavity is compressed anteriorly in adenomyosis. It will cause automatic delinking of fallopian tubes. So you must also counsel these patients for IVF, after the end of the surgery. That is, I think, something which is very, very important in my opinion.
And what about, I'm sorry, I'll just take 1 minute since we are talking this.
Yes, boss.
What about if you open the endometrium? I mean, I have seen this discussion happening in multiple groups and people that we need to close the endometrium, which I don't believe in. So what is your thought?
No, you don't. People don't go and close the endometrium in histoscopic myomectomy, right?
Yeah.
People don't go and close the endometrium in laparoscopic myomectomy, correct?
Yes.
So, and what are you going to close it with? Chalo, I'll ask a reverse question. What will you close it with? Are you going to close it with 3-0 vicryl, 2-0 vicryl, 5-0 vicryl, 9-0 vicryl, what? Okay. Please remember, people who don't know about vicryl should understand that vicryl is one of the most adhesiogenic materials on earth. Okay. That is because vicryl is dependent on inflammatory reaction induced by the body for hydrolysis to occur. Okay. So where any place where you use vicryl, there is going to be inflammation. Any place where there is going to be inflammation, there is going to be scarring. So how can you use vicryl over the endometrial cavity? Correct? Of course, I mean, this is the theory behind it. As a result of which, if you open the cavity, actually you have done a good thing. If there is any hematoma which is formed inside the, your suture site, that hematoma will actually drain out through the endometrial cavity and the patient will have a very good healing of the musculature of the uterus. Ultimately, that is what you want to achieve, a strong integrity of the scar. Okay. And so I'll tell you something. We have put total of 5 mesh so far. Hafiz sir has put 1 mesh and delivered that patient. We have put total 5 meshes, out of which 1 patient we have delivered. So I think Hafiz sir was the one who delivered the first patient after putting a mesh at 16-17 weeks or so. I put it at 9 weeks, where somebody had done an adenomyomectomy and the scar had given way. Okay. All types of fancy things were done in that surgery also. 2-layer suturing, endometrial suturing. Why did the scar give way? Okay. See, the scar gives way because that contained hematoma causes fibrosis inside. And that fibrosis causes a weak muscle. Had you kept that cavity open, that hematoma would have drained, the cavity would have collapsed over it, okay, and the uterine tension would have been relieved, and there would have been very good scar integrity. So please take that point home, okay.
And what is this Osada triple flap method? I've got so many queries because they want to know.
No. See. Okay, it's like saying that, it is Aarti Deenadayal's method of doing an ultrasound. Okay. Right. Forget what is anybody's method. What is your principle of adenomyomectomy? Volume reduction and scar integrity. Okay. How do you achieve scar integrity? By causing a huge volume reduction. You need to overlap the muscle over each other, right? You can overlap the muscle over each other and only then the volume of the cavity will become better. Correct? Only then the strength of the cavity will become better. But one thing people forget, they love it because it is a beautiful name. No, it's like all Japanese names are good. See, Osada's technique, Obakayashi's face. Half the people say Obakayashi, half the people say Okabayashi, but nobody knows where the space is. Everybody is only still fighting on the name. Correct? No? Something like that. happens in this also. But remember, people often forget, in this type of situation, actually the serosa or the musculature which you are trying to approximate is a very hard musculature. It's very, very hard. If you take one wrong stitch, that stitch will cut through it. Okay. As a result of which, whatever flap you want to follow, you can follow flap technique, you can follow closure technique in multiple layers. Please ensure in adenomyomectomy that the sutures don't cut through. As long as your sutures don't cut through, your integrity of the tissue and the scar will be maintained. Otherwise, uterus is a beautiful organ. Give it 3 months after approximating everything. After 3 months, you will see God has healed everything from everywhere, And yeah, but I think, yes, when people talk of Osada's flap technique, people don't like to open the endometrium will be extremely unhappy to know the fact that Mr. Osada has done a lot of adenomyomectomies and he recommends opening the endometrial cavity in all his cases. Poor guy must have not be having access to Vicryl, I think, But he strongly recommends opening of the endometrial cavity in whatever adenomyosis he resects. And then he does an open surgery, obviously. And then he allows for beautiful closure and excellent reconstruction. But the same thing can be replicated laparoscopically, no doubts.
What are your tips for preventing excessive bleeding during this surgery, Jay?
Bilateral uterine ligation.
Okay. What is the suture material that you use?
I coagulate it, madam, or I clip it.
No, suture material used for the flap.
This thing? I use Stratafix number 1, 45 centimeter length, 37 millimeter needle.
Okay. What is your adhesion prevention method post-surgery? Do you do something special?
No, actually we've done so many with you, madam. We put interseed, right? And interseed may or may not be so great, but in our experience, putting that interseed, whatever little work it does, So I think it is better to put interseed there. You may choose to not put it and it will give you an equally good outcome. I agree to that, but I prefer to put it.
Okay.
I don't use any other adhesion barrier apart from that.
Okay. Diffuse adenomyosis versus focal adenomyoma. Is there any difference in the surgical intervention?
Yeah. Focal is very easy, no? Focal is one place where you will not open the cavity. Focal, may your tubes will be preserved. Focal is a smaller surgery. Diffuse is a more tough surgery to do.
Right. Now, the main concerns of surgery for adenomyosis, Jay, is that you're concerned about the pregnancy outcome.
Yeah.
That there is going to be a slightly higher chance of a uterine rupture. 4% is what is, the published percentage, and of course, risk of preterm delivery and abnormal placentation. So your experience regarding the same, all the patients you have operated, how has been their pregnancy outcome?
Pregnancy outcomes, irrespective of how good you do a surgery, is going to not exceed 15 to 20% post-adenomyosis. Okay. And that is something which people should understand. And that is one of the reasons so many fertility consultants don't like to operate adenomyosis prior to doing their embryo transfers. They like to give that GnRH agonist so that they don't have to operate, because the pregnancy rates would drop down. Okay. But the cases, at least what we have seen today, what you've shown, case 1 and case 2, there is no other option but to operate, and then do this thing. As far as the uterine rupture is concerned, as I told you, we've put 5 cases of double mesh so far, which is a intraperitoneal as well as extraperitoneal mesh, which is good, which helps. You just have to suture it. It will form like a dimple over the uterus when the baby is delivered. And it is something which is good, which can be attempted, but of course it should not reach at that stage. That is the reason why you should do a good surgery, which is something which we have been trying to harp upon. And use a good ultrasound machine in the first place to diagnose all this. See, like how Aarti madam is using Volusion E10. Volusion E10 is a damn expensive machine. And the reason, it's an expensive machine, not because of something else, it's a great machine, So people must first learn to invest in good equipments for getting these type of good outcomes, is what I think. Okay. And I could be wrong.
I think you're absolutely right, Jay. And I want to add to this point of uterine rupture. If you look at the first case, which was published post-adenomyomectomy uterine rupture, it was a case of a twin pregnancy. And the second case which was published was one post-adenomyomectomy, the patient conceived within 1 month of the adenomyomectomy. So 2 take-home messages is post-adenomyomectomy, as you just mentioned, give at least a 3 months gap for uterine healing and then go ahead with planning pregnancy. And of course, if you're planning an embryo transfer, avoid double embryo transfer and try to have a singleton pregnancy. Do you agree with me, Jay?
I think so, but then from what I understand is many people still prefer to put 2 embryos in adenomyosis patients due to a lot of logistical factors. But yes, if you are given an opportunity, a single embryo transfer should be the way forward in adenomyosis at least.
Right. A single statement on what would you do for this patient, just to get the a message.
See, this endometrioma is more than 5 centimeters at least. Okay.
Right.
This requires surgery, madam, before even you do an egg pickup. Okay.
Right. With also management of adenomyosis. Now,
of course. With adenomyosis.
Many times the endometrioma blinds the picture and we sort of don't focus on the adenomyosis. So when you're planning surgery, it has to be a combined surgery for both the pathologies.
It has to be mandatorily.
Now, this patient, she has completed her family and she's got a 50.
Aarti, I'm sorry, half an hour is up actually.
Okay. So we'll maybe discuss this maybe the next time, Jay.
Yeah.
Lots of cases. I also have something on, patients going in for IVF with different pictures of adenomyosis, how we treat and what is the pre-treatment strategies we can all share. So maybe this is we'll keep this for the next time, Jay.
Yes. Part 2 adenomyosis. No problem.
Done. And I would want to end with just, one very interesting fact to take home, Jay. These are 2 papers which actually show in thousands of women that when you have adenomyosis, there is going to be an increased risk of ovarian cancer, endometrial cancer, and a 13-fold increased risk of colorectal cancer and thyroid cancer. So this is just a fun fact. And just before we end, a few questions for you, Jay, just 3 of them. How many adenomyom, like a rapid fire, how many adenomyomectomies have you actually done in the last 2 years?
I don't know, madam. I don't have the exact data, but the last year alone, we had done 300 plus. Okay. So I don't have this year's data so far. I'll get it by the end of the financial year.
Okay. And the largest size adenomyosis which you have operated on?
21 centimeters.
21 centimeters.
Yeah.
And one more take-home message, your choice of imaging, because I see many patients coming to
ultrasound.
Yes, that is a very important take-home, because whenever I see many patients with an ultrasound report and an MRI report of adenomyosis. So I think if you have a good ultrasound machine, an ultrasound is good enough, and you really do not need an MRI. So I think we'll end today's session, Jay. There's so much more to discuss, but that will be for part 2 for the next week. And you've given us great take-home messages in terms of what are your choices for pain relief, what is the role of medical management, how long we can give it, a wonderful sharing of your experience of prolonged use of GnRH agonists, what it can actually land up with, and of course about the surgical technique and your experience and how we have to be careful in terms of planning pregnancy a few months later so that we can reduce the risk of rupture. So with this, I think we can end today's session, Jay. It was wonderful, fantastic take-homes. And thank you, almost 500 plus colleagues of ours logged in. And thank you so much.
26.
Yes. And we'll meet again next week with more number of cases, maybe more cases of the IVF patients with adenomyosis, how to manage them.
Yes. Thank you, madam. Thank you so much.
Good night. Good night, everyone.